Hey, welcome everybody. This is UroNurse, your go-to place for urology nurse education. So again, welcome to UroNurse. You know we're live because stuff happens, right? Yes, and we are coming to you live over all of these different stations. Welcome to the show. Keep hitting that subscribe button. We're doing great. This is your first time joining us. Go to uronurse.com to learn more about the show. Best place to learn about our show. Also, best place to check out all our past episodes. Over 2 years we've been doing this now, 109 episodes. Crazy. Want to listen to us in your car? No problemo. Go to our UroNurse Plus area and you'll be able to get our podcast, our audio-only podcast on any of your favorite audio podcasting platforms. So this week, this month, actually, we're going to devote to prostate cancer awareness, and we're going to kick that off with an awareness show. And I'm going to bring in my experts right now. Experts, welcome to the show. If I hit the right button, there you go.
Morning.
Hey, everybody. How you doing?
Good.
So I don't have my normal UroNurse shirt on because I'm supporting prostate cancer awareness. So I did put a question in for the comments there. If you guys that are watching us live can just say what your office does, your practice does for prostate cancer awareness. Our office has this Blue Monday that we're celebrating as a prostate cancer awareness. The employees who donated to this get this shirt, and you can wear your t-shirt on Mondays to the office. Just as a reminder, prostate cancer. So my name is Vic Sinise. I am your host, and I am going to be presenting today. So I'm going to kick it over to my other qualified experts. Andrea, why don't you give your introduction and tell me what your group does?
Great. My name's Andrea Strong. I am a urology nurse practitioner in Wisconsin, and I started my healthcare career as a nursing assistant on an inpatient urology floor. I've done everything there is to do in urology: day shift, night shift, inpatient, outpatient, procedures, telephone triage, you name it. And now I'm very fortunate to be in a situation where I'm able to practice at the top level of my license. And I would like to say that I do prostate cancer awareness every day, and my whole practice does prostate cancer awareness every day of the year, 365 days. We're doing PSAs, we're educating patients and their families, bringing on awareness. Personally, I like to practice prostate cancer awareness with my family and friends, talking to them about the current guidelines on screening and just getting the word out about it. So I'm really looking forward to your presentation today, Vic.
Great. And Lori, go ahead and give your introduction and what you guys do.
Good morning. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been a urology nurse since 1998, and I currently work for Northwestern Medicine in Winfield and Geneva, Illinois. For Prostate Cancer Awareness Month, you had me doing a lot of thinking since last week, Vic. And so, believe it or not, on Monday, on Labor Day, I decided I didn't have much to do, believe it or not. So I went into work and I decorated our bulletin boards with prostate cancer awareness. And the funny part of it is I called my parents, and my dad actually had prostate cancer diagnosed a few years ago. He had his prostate removed, and he's like, "What? I don't get a card?"
Yeah,
but I like it. Yeah, I like all the comments coming in, though. I'm going to steal some examples there. So.
Oh, great. Yeah. I think it's really, necessary to get the word out because there's still a lot of people who ignore basic screening, and it can be catastrophic when you do. But let's get on with our show. I'm going to bring up my slides here, and we're going to start our show right now. So yes, it is Prostate Cancer Awareness Month. The whole month is devoted to it. We'll talk a little bit about what started all that, but let's do a little overview of what prostate cancer actually is. So I know my distinguished audience that comes to this show all know what it is, but I do know that we do have people that are non-professionals that watch the show. And I thought I'd start with the basics. The prostate gland is that organ only found in males. I've had a few females say, "Where's my prostate at?" So it's only a male disease. You ladies are lucky. It forms cancer sometimes with aging for some men in the prostate itself. So that's that little walnut shaped thing you see there at the bottom of the bladder, base of the bladder. So, a little talk about the demographics. Prevalence, it is the most common, one of the most common cancers found in men, unfortunately. It does is affected by age, so that it's primarily a disease that affects men over the age of 50. But it can affect people at a younger age. Quick story, I can remember early on in my career a patient who came in who was 40 years old and he had a PSA that was elevated. And this was before we were really screening in the lower numbers. I mean, I think at the time 55 was a recommendation. And I said, "Wow," I said, "you really had a good primary care doctor who, decided to screen you." I says, "That's unusual at your age." He says, "Well," he said that, "I had a brother who had two brothers that had prostate cancer. My father's had prostate cancer. My uncle had prostate cancer, and he was the youngest in the family. And at 40, had an elevated PSA. And as you probably know the way the story goes, he had prostate cancer. So, although it affects young, men over the age of 50 primarily, keep in mind it can affect others. So there is a ethnicity that we are seeing a higher incidence in African American men and lower in Asian, Hispanic populations. And anytime I, kind of state that statistic, I often wonder what it's based on. And I know there was a lot of research out there talking about diet, but I did find some interesting information I thought I'd share with you guys today on why there's a higher level in African American and maybe a lower level in Asian. Um, they note that huge amounts of androgen are required to induce prostate cancer in virtually all animal models of the disease. So the evidence implies that the cumulative exposure, which is probably why it's more men over the age of 50, to androgen may be important in the development of prostate cancer, suggesting a higher incident rate among blacks may result from larger or longer exposures to it. Now, the assumption is that the black diet, high fat diet, might be an important risk factor. So it must be acting through some hormonal pathway. So that was the thought why they say that maybe it's a dietary thing, the higher fat black diet, the lower fat Asian diet. But Ronald K. Ross, MD, found that testosterone levels were 50% higher in African American women than in white women. He speculated that this increased hormonal exposure in utero might reset the so-called gonadostat feedback loop, which regulates testosterone secretion to a higher level. So, a follow-up study of healthy young men found that circulating testosterone levels were 15% higher in African Americans than in whites. The difference may not seem large, but remember, this is over a lifetime. So it's, again, we say at the age of 50. So this is happening over their life. So this increased exposure of just 15% could explain the 70 to 80% higher rate of prostate cancer found in blacks. Now, conversely, they looked at the Asian diet. They did a study in Japan and found to their surprise, this was with Ross's group, that the testosterone levels were very similar in Japanese men and white males. White. But the study also suggested that Japanese had a lower activity of 5-alpha reductase than U.S. whites and blacks. This is the enzyme we know that metabolizes testosterone into dihydrotestosterone, or DHT, which is at least 10 times more potent than testosterone. So I thought that was kind of an interesting explanation. I'd never like to just take anything at word value. Mortality, it is the second leading cause of cancer death in men next to lung cancer. And I think with the falling rates of smoking, it's probably going to take over. So what are the risk factors? Well, increase with age. We talked about why that is, but the family history, that story I gave you about that young patient, men with a family history of prostate cancer are at a higher risk. And our guidelines even specify that we recommend screening at the age of 40 to 45. So that guy was right on the money. And then we talked a little bit about African American men's higher risk for prostate cancer. It's definitely out there. So if you're a black American, please get out there and get screened. All men get screened, but it's even more so. This other one was kind of interesting. High fat diet and obesity may increase risk. Of course, I can't leave that alone either. So I did look for some studies at what the association was. And while being overweight or obese doesn't seem to cause prostate cancer, it may increase your risk of developing an aggressive, fast growing form of prostate cancer that is more difficult to survive. So by losing weight, you may be able to lower your risk of problems with prostate cancer. So you're going to learn a few things here on UroNurse. Um, Other factors like chemical exposure, smoking, sedentary lifestyle. Exactly. So, what are the symptoms of prostate cancer? This is one I think all of us that work in the field have patients look at you when they come in with that elevated PSA and you say, well, based on your studies that we've done, you need a prostate biopsy. And they're like, but I have no symptoms. I'm fine. That's the problem. Early stage prostate cancer, the most curable form, is often without symptoms. So those are the patients that we need to screen, especially in our population of younger men. Younger, I mean, like 50 guys my age up to probably 70s, and heck, the way people are living now, even up to uh, into their 70s. We don't want to wait till there's advanced stages. So, and I always tell patients, it's a good thing if you're not having symptoms, because if you were coming in here with the symptoms of prostate cancer, it's probably spread somewhere. But issues like urinating, blood in the urine or semen, erectile dysfunction, and primarily bone pain, that's a big one. Sudden increases in weight loss that you're not dieting to do. Those are all things that can cause this. So what about diagnostic testing? How do we test for prostate cancer? Well, PSA has been probably the biggest movement forward in finding early prostate cancer. So all testing has two things that we look at. It's how sensitive is it? Is it really going to detect very low levels? And how specific is it? Is it going to detect just what you're looking for? So PSA, and there's been a couple talks I've done in the past on that. We know it's a very sensitive, very early caught prostate cancer at the microscopic level when you find elevated PSA, but it's not specific. So that means it finds things that aren't there. So we've got some measures now that we can fine tune the PSA, such as looking at what the percent free PSA is. When it's elevated and the free PSA is over 25%, you may still be low risk. Digital rectal exam, another screening exam. That one is actually kind of, my latest research has shown it's plus or minus whether you need a digital rectal exam. And, it's kind of been the PSA DRE, every male over the age of 50 should have it. And it's kind of gotten away from that a little bit. I think that because again, sensitivity, not very sensitive. By the time you're feeling a nodule with your finger, this is probably either advanced prostate cancer or, and because I'm involved in prostate ultrasound a lot, it's probably a stone in your prostate. So a lot of those lumps and bumps they feel are not cancer. So it's not very specific. It's not very sensitive. It's probably not a really great exam, but not it's controversial as to whether you do it or not. One of, I think, the reasons that DRE is falling out a little bit is I think a lot of men shy away from prostate cancer testing, the screening, because they're worried about getting a rectal exam. I don't know why. I've been through one. It's not gonna kill you. But anyway, I think that if you take that out of the equation, more men will be more likely to get screened. And interesting, my very first PSA I ever had done was at a prostate cancer awareness fair. Happened just turned 50 right at that time, and they were giving out free PSA. So I went there, and I was expecting the DRE at that time too. And they said, no, we're, even back then they said, we're kind of getting away from that now. So anyway, the only way to really diagnose prostate cancer is by biopsy. You have to have tissue confirmation. So you may look at it and say it's definitely got all the symptoms and everything that we want to see that would equate to prostate cancer, but you have to have a tissue diagnosis. There are some imaging studies. MRI is jumping way out there with some really great information. When you can see a nodule, you can detect these much earlier than you would with a rectal exam or with even ultrasound. The MRI is much more sensitive with something called a PIRAD score. When that's abnormal, higher risk of finding prostate cancer. Plus, you can use that to target directly. Most biopsies, for those of you that may not know about biopsies, are done at what we call a sequential staging. We look at different areas, specific areas of where prostate cancer is the highest found. Not that you're always aiming at a nodule, you're aiming at specific areas from the base of the prostate to the front of the prostate, there, the apex of the prostate. mostly on the outsides because that's where most of these prostate cancers. But you got a prostate all over the place, so you could miss something. So having something like an MRI can be helpful. Staging prostate cancer, like all cancers, it's a stage of 1 to 4. 1 is the best. That's confined to the prostate cancer, to prostate alone. Stage 2, it's confined to the prostate, but maybe more advanced. By advanced, we look at this thing called the Gleason score. Gleason scores are 2 scores of how the prostate looks under the microscope to the pathologist, and they score it on a scale of comes out 1 to 10. They add the 2 numbers together. Well, 2 to 10, because I never saw a 0. I never saw less than a 3 plus 3. So 6 is kind of like almost they're saying not cancer. It's so early. But anyway, as it gets to higher levels, those would be advanced, but still could be to the prostate. Stage 3, it's spread beyond the prostate to nearby tissues. And then stage 4, it spreads to other parts of the body. So those are the worst ones. That's not where you want to diagnose prostate cancer. So what are the treatment options? Well, the top one, surveillance, is relatively new. It's come about over probably the last decade or so, but monitoring low risk cases rather than treating, because they're finding that we probably were overdiagnosing prostate cancer. Remember that PSA is super sensitive, maybe too sensitive. So we have some of these biomarkers now that can fine tune who really needs to be diagnosed. We don't want to be finding these these low grade prostate cancers. We consider the 3+3s low grade, because the risk of those going on to become something that's going to be life threatening is very low. Again, they're even looking at some renaming of those so that the word cancer comes out of it. So again, active surveillance. If you have one of these lower grade tumors, you can watch it, see if it's progressing. You can follow it with all these biomarkers and PSAs and all these other good things. And sometimes going back in, rebiopsying to see if that Gleason score is going up or not. Otherwise, we do have surgery, radical prostatectomy, to completely remove the prostate. That's been pretty revolutionized. In the old days, we did open prostatectomy to remove it. Now it's all done. Most of them are done robotically. The recovery is much quicker, much less pain and suffering to go through. So it's really a great improvement. Radiation therapy has also been, in the old days, they blasted everything around the prostate. So there was a lot of rectal issues and things like that from it. But they're so fine tuned now that radiation therapy can just hone in on the prostate area itself. Brachytherapy, which is radioactive seeds. There's even some studies where they place seeds just around the prostate cancer that's known. So they're kind of doing this targeted prostate treatment. And there's some others that we've talked about on our show. Hormone therapy reduces the levels to slow the growth of prostate. It doesn't get rid of it, but it does make it shrink down. Chemotherapy, there's a lot of new things coming out, and immunotherapies. Drug Keytruda is used to fight everything, including prostate. So again, advances in prostate cancer treatment are just flying off the roof right now. And I think it's a lot of the awareness that's helped to do this. It's gotten the money, the funding to do these studies so that we can find these targeted therapies, do more clinical trials. And who knows? I kind of hope to see someday that they'll have a vaccine to prevent prostate cancer. Now, if you get prostate cancer, is life over? Of course not. Most prostate cancers caught early have a huge survival rate, like 100% survival rate after 5 years. If you catch an early prostate cancer, compared to an advanced prostate cancer, which 35% 5-year survival rate. But quality of life, managing the side effects, all this stuff, we've gotten a lot better with it. Actually, even with the more advanced prostate cancers, there's a whole new form of urology medicine called advanced prostate cancer management, and it involves a team of nurses and doctors who are just dealing with these advanced prostate cancers and really have a great system in place. We talked about these groups here. They're great for supporting each other, kind of getting the word out there, counseling. So get involved in those. And then lifestyle adjustments, diet, exercise, regular follow-ups. Wait a second, put the brakes on. Let's not jump by that lifestyle adjustment too fast, because most of us do. We just say, yeah, yeah, right. We should eat better. We should exercise. There's more to it than that. I've been listening to a few different shows and doing some research. Um, there's a kind of a movement going on where we're looking at our food supply might be what's causing some of these issues, might be what's causing some of these cancers. The ultra processed food that we've all been fed most of our life, myself included. Although they're convenient, they make things last forever on the shelf and in your house. You know, I'm a big proponent of what they're looking at now called single ingredient cooking. So it means if you need to use your chemistry degree to understand what's on the label, it's not single. Salt, water, garlic, things that are single ingredients, and the fresher the better. If you can get away from the canned foods and go to your local farmer's market. I live in the country. We've got fresh produce everywhere. And I even grow some of my own, so I can get it right from my porch. So it's a improving diet, I think, is going to make a big difference on the risk of prostate cancer and all cancers. And watching those ultra processed food, we need to start cutting those out, especially for our next generation, our kids. All that high fructose corn syrup causing a lot of problems with our biggest issue, which is obesity, because it satisfies the sugar part, but doesn't satiate your hunger. Exercise. We all want to just get right over that one. Well, I've been watching the exercise data back early on, like probably most of us when I was pre 40 in my 30s. I figured, I do enough walking at work. I'm always getting enough exercise, and kind of ignored it, as what I probably should have had it, in my life. Believe it or not, I was an athlete in school, so I did swim every day. So I kind of got away from it. And then I started reading some of this research, and the research, wow, the sun just went away. The research is really strong on what exercise's effect on decreasing your risk of heart attack, stroke, and cancers. And it's simple exercise, 30 minutes of aerobic exercise every day. Aerobic means heart rate's got to go up. So if you've got a watch like I do, you can monitor your heart rate and make sure you're getting it to go up. As you get older, running gets to be kind of hard on the knees, but I found that swimming, I don't swim, but swimming is a great exercise. Bicycling is another low impact, but great aerobic exercise. I bike every day. I love it. So go ahead and exercise more, and regular follow-ups does make a lot of sense. So I did want to look a little bit into when did we start getting aware of prostate cancer? So what got us this awareness? And in 1989, a decade before the creation of the National Prostate Health Month, the week of September 17th to the 24th was chosen as Prostate Cancer Awareness Week. So back in the 80s or late 80s, 89. And then in 2001, a Senate Resolution 138, sponsored by Senator Conrad Burns, endorsed the week and affirmed that Prostate Health Month would be observed annually. And then in 2003, by presidential proclamation, George W. Bush put it into effect. So it's been around, but it's been around fairly recently, only the last couple of decades, that we've been more aware of our prostate cancer and that we need to get the word out, which has led to a spread of a lot of different organizations that are involved in Prostate Cancer Awareness Month, the Prostate Cancer Foundation, Zero End Prostate Cancer. That's one that we get involved with. American Cancer Society, of course. Us Two International, another nonprofit that's involved. National Comprehensive Cancer Network, and the Men's Health Network. All these can be found online. All these have some different type of promotion or awareness programs going on. And again, Zero Prostate Cancer is the one that our local chapter, Chicago Metro Soon, has been involved with. They do a yearly walk in September. Get a lot of good advertisement out there. September is Prostate Cancer Awareness. Our own organization also has involvement with these walks. And there's going to be 17 run/walks. I don't do the runs, I do the walks, happening across the country in all different states. You can check in at Zero Prostate Cancer online, look it up, and find out what's going on. Since I'm with the Chicagoland area, this is what Chicago's doing. It's September 22nd. you can join and be part of the walk run group. It's a 5K run walk or a 1 mile walk. And it's going to be highlighting survivors and caregiver recognition. You can even have a kids dash, nice area of Chicago. And they're even going to have a post-run walk special event at the Chicago Cubs Wrigley Field. So I did put the website there on the bottom if you want to get involved with the run walk area, because that's what we're talking about, is getting more involved in this prostate cancer awareness. That's what we're looking at for today. So let's go ahead and bring in I got a couple more things before I do that. UroNurse, again, I said this month we're supporting prostate cancer awareness. All of our programs are going to be on some prostate cancer topic, but there's a bunch of them already in there. So go to our past episodes, go to uronurse.com to see some of these past episodes about PSA testing and treatment options. And there's a bunch of them. And next week, we're going to be talking about PSMA testing, which is a new next generation in imaging studies. This is going to be a kind of a neat program. It's going to be a long one. It's two physicians that are talking. One's a urologist, the other is a radiologist. So I think it's going to be a great talk. It is also offering 1 CE for the attending, but that one's going to be next week. And again, I will warn you, it's an hour-long program. So we're not going to have any Q&A, but join us to watch it. Also, September 21st, the next month, we're doing prostate biopsy strategies. Survey says, and for those of you that have filled out the survey, many of you have, I did send out a survey to everyone just to kind of get an idea of what you're doing in your practice. We did this for the cystoscopy. I thought it really was a great thing, and we're going to have our experts join us to kind of discuss what the practices, what the survey shows, and what we think that means. So another fun thing to look at. The following one, we're going to be in, I'll be in Orlando. So at our SUNA meetings, I'm going to try to find some theme prostate cancer throughout the meeting, but we're going to have something live from there. So now let's bring in our experts. Experts, welcome to the show.
Thanks, Vic.
So do we have any good comments out there, Lori, that you could share from our audience?
Oh, absolutely. So, Vic, in the beginning of this presentation, I had wanted you guys to find out how your practice supports prostate cancer. So we'll go around through those. April said, before COVID, we held 2 prostate cancer groups, one for men and one for women. These meetings were open to everyone and took place twice a month, led by our cancer and care coordinator. That's great.
Yeah, that's great, because that support, I think, is really necessary. You know, people, when they hear the word cancer, they just panic. It's life-changing. So I think you need that support, and especially when you can kind of get together with somebody that said, oh, I've had cancer diagnosis 20 years ago, and they look fit and they're doing fine. It helps you know that this is something you can beat.
Absolutely. And then Susie said our docs used to shave their heads for prostate cancer awareness, but as they got older, they stopped doing it. Probably because they were thinning out, right, Susie?
That's right. It didn't grow back as fast.
And then Charlene said that it looks like with USTOO Prostate Support Group has helped promote through an evening out for all with special speaker, good attendance with vendors. This year will be at Union Baptist Church.
Oh, that's great, Charlene. The Us Two group is another great organization for prostate cancer awareness. All right. So any interesting things that you didn't hear before that I kind of brought out that you want to talk about, Andrea?
The one thing that was on my mind as you were presenting is thinking about early onset prostate cancer. And I can recall the youngest patient that I took care of, status post radical prostatectomy, was a 36-year-old.
Yeah.
So it just got me thinking about prostate cancer screening and when should we start. The guidelines, it depends on what source you're looking at. The guidelines have huge variations, everything from starting at age 40, Some say start at 50. Some say start at 55. Some say stop at 60. Some say stop at 75. So what I do in my practice is I just use the broadest recommendations that I can find. So if someone had a family member with early onset prostate cancer or any of those other high risk factors, I will start a PSA starting at the age of 40, just get a baseline and move forward with screening. And then as far as the frequency of screening, that also varies greatly. Some guidelines are saying annually. Some are saying every 2 years. Some are saying every 4 years. I err on the side of caution, so I tend to do annually. And I'm still doing the digital rectal exam. I can think of a few cases where our advanced practice providers did digital rectal exams, found a suspicious lesion, even with a normal PSA, but they moved forward with an MRI and did find some aggressive prostate cancer. And I think it's a level C evidence in the guidelines. So it's not a very strong, scientific guideline there, but I think physical exams are important. I don't think we should remove them from practice entirely.
Yeah. And that's a good point because some people may not be aware of this, but there are some prostate cancers that don't produce PSA. So that you won't pick it up. A PSA being a good test, not the perfect test.
Yeah.
Yeah, it's always sad to see, how many people with advanced stage end up, the reason why we find out is because they ended up in the ER with bone pain, or they can't urinate, or they got they have gross hematuria. I mean, I remember one gentleman, I'll never forget this gentleman in my career, that he had a very high PSA to present and didn't do anything about it for 5 years and presented with gross hematuria and the inability to urinate. And it was pretty bad. It was far. I don't know about you guys, but what's the highest PSA you guys have ever seen? Audience, what's the highest PSA you've ever seen?
So Lori, why don't you start off?
I'm going to start off because this was incredible. And we actually had it checked again because we thought it was a lab error, but it was 98,000.
98,000.
Yep. I mean, the gentleman passed very, very shortly, obviously, after that. But it was, but he walked in, he was still golfing. I mean, it was crazy, but yeah, that's the highest. It was a shocker.
Wow. Andrea?
900s.
900. Yeah. I've seen several of the hundreds. I've never seen 98,000. I've had a few up in the 10,000s.
Yeah, it's insane.
It does. You can get some crazy high numbers. And we get anything from the audience with numbers?
Not yet.
Not yet. Come on, audience. Don't be shy. But yeah, so and you see the opposite too. I had a patient early on in our career that had a PSA of 30. I mean, generally anybody with a PSA, I always say if it's 10 or below, you're probably going to be, you probably stand a pretty good chance, at least 50-50 of being negative. It's going to be a non-cancer. If it gets between 10 and 20, now it flips the other direction. Your percentage of finding cancer is going to be higher. At 30, those are pretty often going to be positive.
And how about those people with the enlarged prostates that have PSAs normally of over 10? And they don't
prostates that can produce. So this guy with the PSA of 30 had 5 prostate biopsies because the urologist just sure that he had a decent sized prostate, that we had to be missing it. All 5 were negative. So sometimes you can have a high, what would be kind of concerning number and still not have cancer. So he died of old age.
Yeah, we have to remember too that people who are those, the ProScar, the Avidart, things like that, just make sure that you're looking at that PSA, because patients will say, oh, my PSA is better. Last time it was 6 and now it's 3, but they're on one of those medications. And I believe it's after 6 months, you have to assume that their PSA is double that number. So they may think it's better, but it's actually the same as it was last time. It's just because they were placed on one of those meds.
That's a good point, Lori. I find that I have to re-educate patients every time they come into the office. I usually put it in my note as a reminder to myself and all other practitioners that they're on one of those medications, Proscar, Avidar, and that any PSA level while they're on those medications needs to be doubled for the real value. And every time I remind the patients when I come in, many people forget, oh yeah, I forgot about that, but now I do remember. And for those patients, Vic, that you were referring to with a really large prostate, so the larger the prostate, the higher the PSA level. You could consider using like the PSA density test. And that's when you take the PSA number and you divide it by the volume. And then you can get a number. So anything, less than 0.10 is reassuring that that PSA level is where it's at because of the size of the prostate and not because of prostate cancer. So it's just another tool in the toolbox. And speaking of tools in the toolbox, there's so many out there as far as biomarkers and the free percent PSA and the PSA density. Is anyone regularly using biomarkers in their practice?
We are. We rarely do a biopsy based on PSA alone. So it's always going to have a follow-up test, free and total PSA. Most of our PSAs, we order what's called a reflexive. So if the PSA is over 4, it'll reflex automatically to a free percentage.
We usually use the Prostate Health Index, the PHI.
Yeah.
We did get a comment from Nisha that her highest PSA she recall is 1100.
Yeah. So it's crazy how high that number can be detected.
Mm-hmm.
As you said, 98,000. Sometimes you just get these patients who come in, and most of the time when you see those super high numbers, the 1100s, even the hundreds, those patients look like they got cancer. There's if you've been in the business long enough, you just kind of see that look that people have from when they've had advanced cancer. So it's you don't want to be one of those patients who waits that long.
Oh, and of course, you always have to rule out other reasons besides even a large prostate for elevated PSA, like prostate infection, UTI, things like that can cause that elevation as well.
That's a good point.
There's something that's called a prostate infarct, where part of the prostate dies off. That can also elevate PSA. Don't see that very often, but it's possible. So. All right.
Vic, while you were presenting, I was actually looking up some of the newest research on the biomarkers for prostate cancer screening. And for the audience, there's a lot of really great publications out there on the different types of biomarkers and when to use them. And are they a blood test or are they a urine test? Do you need to do a digital rectal exam before the urine test? There are many available, and it can get the waters can get a little muddy with the amount that's available. So there's some great articles out there that'll break it down. They even give you little graphs and nomograms to follow if you wanted to incorporate one of those biomarkers into your practice. And for anyone who's involved with prostate cancer screening, some of the references that I use commonly in my practice are the American Urological Association guidelines. They have a very easy to use app that you can just download on your phone. You click on the prostate cancer screening and it gives you some very clear guidelines. And anyone who works in healthcare can also get free access to the NCCN guidelines, and that can help guide your practice.
Yeah, it's amazing how many, even primary care physicians and patients aren't aware that, you get that PSA number back. And it may be 0, the guide or the lab values are 0 to 4. But for somebody who's 50 years old, you don't want that PSA at 3.5 or 4, the higher. So it is age specific, and patients and primaries a lot of times don't, the patients don't know, primaries don't follow. So.
Yeah, good points. What about the data I presented on African American having higher rates for those reasons that I was kind of unaware of? I've always heard of, maybe it was related to high fat diet amongst the African Americans, but the higher exposure to testosterone levels in utero was a surprising one to me, and that they have a higher testosterone level in general and that exposure over time. That kind of makes sense.
Yeah, I think we need to do more research on patients, and if you look at the studies that are done currently, it's mostly males, white males, and I think we need to diversify the study populations so that we're being inclusive of all populations. Because
Yeah,
I think the jury's still out on why are the outcomes not as good in that population. There's a lot we can learn from more research.
absolutely. And it's a shame that, as you say, the particular race that probably needs the most screening tends to be the ones that shy away from it the most. So there's a lot of getting information, to all races is important so that we get proper screening. Because don't be afraid. I heard that one of my African American patients said that his barber was the one that was spreading the awareness to all the guys coming in. Hey, you got to get this checked. This is happening to black men. So, however you get it, become aware.
Yep.
All right. Well, if we don't have any comments coming in, I have no problem with ending the show a little early. Great way to kick off, I think, for prostate cancer awareness. The whole month again is going to be prostate cancer, so stay with us. And any thoughts that anybody has during the month that they want to talk about, let me know. I'm just going to cover a few things here. Here's the intro or the plug for next week's show.
PSMA imaging has become a key part of prostate cancer for diagnosis, disease staging, and assessing response to therapy. In recent years, several novel PSMA-targeted radiotracers have been developed for PSMA imaging. These are more sensitive, specific, and accurate than other imaging modalities. Join experts Dr. Jason Hafron and David M. Schuster, who discuss best practices for the use of PSM PET, CT in prostate cancer. Coming next week on UroNurse.com.
So yeah, be sure to join us next week. That's going to be a real interesting talk. For those of you that are not healthcare workers, remember that the europatient.com comes on at 10:30. Not starting today, but the rest of the month, prostate cancer awareness is going to be on the Europatient area too. We're going to have some specifically aimed at patient awareness stuff that I'm going to be talking about. So check that out. And if you are a healthcare worker, check it out too. There's going to be always some interesting stuff to find out. All right. Hey, for those of you that are going to the SUNA meeting in Orlando, please come around and say hi. We're going to try to see if I can get SUNA to give us a booth somewhere to kind of meet and greet people. But I'll be presenting for 2 different talks at SUNA. So check out my talk. Be glad to say hi to everyone if you come and visit there. But I'll be doing a talk on technology. Big surprise, right? Why I think this particular format is going to be the future over the traditional SUNA type sit down meetings that we've had in the past. But you can come and see what that has to say. And then I'm going to be doing one that's more aimed at new people to urology. It's going to be setups for cystoscopy and vasectomy. So be sure to join me over there in Orlando. It's supposed to be a neat place. We've never done SeaWorld before that I've been involved with SUNA. So I'm kind of looking forward to seeing what that's like and just getting down and spending some time together. I know you guys are all coming to the meeting, right? Andrea and Lori? Good. We'll have to try to see if we can coordinate I'm going to definitely have the show live from SUNA. So we'll try to coordinate that when we're down there.
Oh, before you go, April said she received a SUNA scholarship.
Hey, April. Congratulations.
You, April.
Be sure to stop by and say hi. So, all right. Well, with that, have a great weekend, everyone. It's going to be a cool one here for us. Hopefully you got the nice cool weather too. I was out in my I told you we grow a lot of our own stuff. I've got a grape yard, or a grape, what do they call it? A vinery, whatever. I don't know. I got grapevines in my backyard that all need to be picked. So I got to go out after this and start picking grapes. So we'll see what we're going to make out of them. They're Concord, so they don't make great wine, which would be a shame, but they make delicious jelly and grape juice. So we'll be doing something like that today. So the rest of you have a great weekend, great week. See you all next week.
Bye-bye, everyone.